compound, so please bear with me. It's a very stupid thing, right? I'm already over 50, so things just happen. Anyway, I will have. Okay, compared to just a few years ago, dental implant treatment has become more common in Vietnam. Along with that, many of you are also very interested in bone reconstruction surgery. So today, I'm going to focus on this topic, especially on how we can manage and overcome severe defects. I also understand that recently, Boston Zeno has been introduced in this country. So as a user who has been using this material since its early development, I would like to share my interpretations with you. Before going into Boston Zeno, let's first take a look at some key points that are essential for successful regeneration. Overcoming proven conditions means undergoing regeneration process. For that, you need to well-established stretches, high levels of structural skills, and the biomaterials leading to optimal results. When it comes to stretches, it is important that you clearly evaluate the need for body maintenance. Let me start by showing these slides. These slides give you two different patients at their first visit to my clinic. You can see shielding plan was placed in vertical position plan. In the lower slide, regular sizing plan was placed in the posterior. According to the patient description, this patient didn't have any augmentation surgery. So you can see also that there is what they offer the skin performance below. So, what is the fate of these implants? Eventually, these implants have to be removed. To the patient, this was nothing short of just the situation is devastating for us. The key point here is that implant failure always means bone destruction. Accordingly, for long-term implant survival, there must be a bone sufficient bone, and it should be advised correctly from the very stage of implantation. In cases of severe orbital baldness, either in maxilla or negative, you are facing a very tricky situation. In such cases, if the vestibular bed is sufficient and the carotid tissue is immobile and adequate, and the patient has the ability to maintain good oral hygiene, then sometimes we can manage the situation very simply, only using shielding plants. But in practice, that's rarely the case. Regeneration of bone tissue in vertical dementia is required. We all know that vertical augmentation surgery is difficult and hard to achieve, and the result is not always predictable. But interestingly, the data, the evidence always shows that in most of the cases, we can achieve a predictable bone rate around 45 millimeters. So I believe that many challenging cases can be successfully managed by adapting a strategy of vertical augmentation aimed at gaining 4 to 5 millimeters of bone. Even though short or extra short implants are used, vertical augmentation surgery is still necessary. In words, vertical augmentation is needed even just to accommodate short or extra short implants. In clinical practice, we often encounter narrow edges. Even in these situations, the strategy to create sufficient bone to support implant remains valid. I believe that even in cases where narrow diameter implant must be placed, performing a lateral augmentation is far more advantageous than placing it without any augmentation. When it comes to biomaterials, we need to understand the essential role of bone substitute material in bone regeneration process. There are three crucial elements involved in tissue regeneration. They are viral cells and molecular mediators such as growth factor and scaffolds. These three elements need to work together for successful bone regeneration. So representative example scaffold is the bone substitution material we are very familiar with. It seems that the lot of only one substitute material is somewhat limited in this process since cell or molecular mediators takes greater part in bone regeneration. To explain how bone substitute materials contribute to the bone formation process, I will show the following. This is the very simplified version. Bone consists of a collagen matrix embedded in hydroxyapatite. Bone has nanostructurally low crystallinity. Bone substitute material has no vitality. When these materials are applied within the site, so a favorable environment for successful bone regeneration should be prepared. In order for these non-vital scaffolds to function with vitality, there must be blood supply. As blood is supplied, cell migration is followed, and cells secrete various signals to exchange each other, and the cascade of bone regeneration begins. For example, osteoclast secretes specific enzymes like MMPs. MMP is the abbreviation of matrix metalloproteinase. These agents break down the collagen matrix. During this process, the growth factors that are embedded in the matrix are released. The most valuable growth factor is BMP. BMP plays a crucial role in guiding mesenchymal stem cells and transform into the differentiate into the osteoblast. In this process, the bone substitute material functions as a scaffold literally. It serves as a platform for cells and signaling molecules to interact and facilitate their activities. When everything is prepared as described, the bone formation begins and occurs quickly, with most cases following the osteoconduction mechanism, which means bone regeneration initiates from the native bone surface and gradually extends to the distant from the native bone surface. So, strictly speaking, bone graft materials do not make the bone tissue on their own. More accurately, they simply support and contribute to the bone formation process. As a result, the initially formed human bone undergoes a series of bone making process that eventually transforms into lamella bone. During this remodeling process, bone substitute material plays another significant role. Recently, the concept of the importance of the scaffold remaining intact has been emphasized. The defect filling the emerging bone tissue should not be considered regenerated. Hence, many scaffold-based therapies have failed in the past as the scaffold degradation was more rapid than tissue remodeling. It is now recognized that the onset of degradation should only occur after the regenerated tissue within the scaffold has remodeled at least once in the natural remodeling cycle. In a word, good biomaterial, good bone graft material should be able to keep the newborn tissue. Okay? Then, what should we do in clinical practice? First of all, we need to select an appropriate bone graft material and create an environment in which they can function properly. Unfortunately, no single graft material will fulfill both bone permeability and volume maintaining ability. So we need to use composite bone graft, especially at the critical size defect. Secondly, it is more important to use high quality of membrane that can effectively protect the grafted site. Additionally, in many cases, suture technique or fixation techniques is encouraged to ensure proper wound stabilization. This helps to maintain the integrity of the grafted material and prevent any disruption to the regenerative process. The choice of membrane fixation technique should be tailored to the specific clinical situation. Finally, the importance of the primary flap closure cannot be overemphasized. No matter how expensive or high quality of bone graft material membrane are used, successful results can never be obtained if the wound stability is not obtained, the primary closure fails. So I want to reiterate that the bone surface materials do not create the bone tissue themselves. They facilitate an environment in which various cells and signals can effectively function constantly in bone formation. Okay, and now let me introduce osteon first. Osteon is the first generation bone graft material made by dentin possessing excellent osteal conductivity. Osteon have been used for more than a decade, and it has shown excellent performance as a scaffold. This is the patient I showed you earlier at the beginning of this lecture. These short implants were eventually removed. And in this situation, bone defect was so severe body current that even structural implants could not be placed. Body augmentation surgery is deemed mandatory. In brief, in this case, I selected dentin patent plate as a space-making device, reduced space-making device. The reference technique is Dr. Merrill's space technique. After cortical bone preparation, the pre-shaped patent plate was placed rigidly using a dentin screw. And then composite bone graft consisting of osteon 3 and one kind of rare graft and small amount of autogenous bone added. Densely packed. The whole defect was filled with this composite graft. Since our laboratory alone tends to undergo rejection, I prefer to use it in combination with osteon 3 to enhance performance and stability. This is a strategy that aligns with the concept of the importance of the scaffold remaining intact. Then, 4 pieces the large size of the dentin collagen membrane type 1 was applied to cover the whole wound side. The entire defect was sealed tightly. After buckle and lingual flap releasing and using matrix suture, evolving matrix suture and modified matrix suture and interpretive suture, a primary flap closure was gained. Healing was uneventful. Any complications such as membrane exposure did not occur during 9-month healing period. As you see in this case, all measures have been taken to ensure that osteon 3 non-viral scaffold can function properly. Then, what will be the result? This is 9 months healing outcome at the time of implantation surgery. Although sufficient amount of newborn is found, this is immature. The further protection is needed. These are the photos at the time of second stage surgery, and 4 months after implantation surgery. The more dense, mature bone tissue is found. Okay. The left slide shows the previously collapsed ridge. The right slide shows the provisional restoration. Restored ridge, collapsed ridge was restored much. This is legit at 1 year. Looking at this X-ray outcome, newborn tissue is found above the implant platform level. However, it might not be completely mature, not yet. So, what will be the fate of these newborn tissue? Will it disappear or will it be maintained? If osteon 3 is a decent biomaterial and has effectively acted as a scaffold, mature bone will form in the end and its volume will be maintained, right? I skipped the interim result, and this is the 7-year outcome at the latest visit.
Thì đây là
How is it?
7 năm sau khi follow up.
These are a series of panorama X-ray of this
Cái chất
patient.
lượng xương trên phim X-ray
New crystal lamina is formed evidently, and the bone level is maintained above the implant platform level, and trabecular pattern is formed
cái thể
and
tích xương
visible
trên
clearly.
implant nó vẫn được duy trì.
If these things demonstrate that augmented material became a real mature bone tissue, the point is that osteum 3 was used, and the favorable environment for osteum 3 to function properly was prepared. In the end, successful outcome was achieved even in this severely compromised case.
Trong cái việc là duy trì những khoảng và cái tạo xương.
I will present another body augmentation case. In this case, I used the bone graft material, or just one kind of allograft material. Anyway, this case ended in this way.
Thì cái ca này được kết thúc như thế này. Tôi
This
vẫn
case has
sử
been
dụng
followed
cái
up to
tác
9 years.
sử dụng xương ghép.
Allograft was the sole graft material in this case. Looking at this X-ray, you can see significant bone rejection, unlike the previous case where the osteum 3 was
Trong cái ca
applied.
này tôi sử dụng allograft.
This is why I always prefer
Thì các bạn
using
sẽ thấy là
composite
sau
bone
khi điều
graft.
trị xong á, thì cái lớp xương nó có cái sự tiêu đi ở
Okay,
trên
body
sau
augmentation
đây là
is
cái
quite
bộ phận
fixed.
của implant.
But on the other hand, with body augmentation become easier if there is a bone graft material that could produce more predictable results. In that sense, I would like to introduce osteum xeno.
Mình cũng làm cho cái chứng kiến của cái điều trị khớp xương nó.
Osteum xeno is the second generation bone graft material made by Dentier.
Thì
It
cái
is
xương
bovine
osteum, cái
origin.
loại xương dị loại Xeno loại 2 mà mình thấy là nó
Osteum
được
xeno,
tổng hợp
as
từ cái
it
phần
is
xương.
derived from natural bone tissue, it provides high tissue biocompatibility.
Thì mình sẽ thấy là nó có
However,
cái
its
tính
core
hợp sinh học rất
interconnectivity
là
may
tốt.
be more limited compared to synthetic osteum 3.
So với lại
Compared with
osteum 3
synthetic
là cái
osteum
loại xương
3,
tổng hợp,
osteum
mình
xeno
sẽ thấy
contains
là
more
nó
natural
có cái tính
components,
sinh học tốt hơn.
showing
Nó
superior
có
osteochondritis.
cái tính dẫn đạo xương.
Therefore, it may be easier to use in this material to use this osteum xeno in daily practice, as
Cho
the
nên là
outcome
tôi
is
sử
less
dụng
influenced
xương
by
osteum
surgical
xeno
steroids.
trong cái thực hành hàng ngày.
And favorable outcome can be achieved in a more consistent way. If you don't have any experience with osteum product, it would be better to start with osteum xeno.
Nếu như các bạn
Okay,
chưa
then
có
let's
sử dụng
take
xương
a
ghép
look
thì
at
tốt nhất là các
clinical
bạn nên
cases
bắt đầu
of
với lại cái
osteum
loại
xeno
osteum
from now
xeno
on.
này.
I want to check out what clinical performance osteum xeno
Thì
has
bây giờ
shown
tôi
so
sẽ trình
far.
bày cho các bạn nghe những cái
Since the new
kết quả lâm
product
sàng để sử
has
dụng
not
của
been
hệ
fully
thống kết luận.
validated yet, so it will be too risky to apply it directly to the critical defect from its first use. And therefore, it is
Đây là cái
advisable
ca
to
lâm
start
sàng
with
đối với
relatively
tôi
safe
thì tình
case.
trạng là implant đã
Even
có
so, it is difficult to appraise the clinical performance of a specific bone
thì
graft
mình sẽ thấy
material
là
accurately
cái gen
when it is
đã bị
applied
lộ
in a
và có
contact
cái khuyết tật
defect,
xương
even in sinus area. So I have used the osteum xeno in the
cho
following
nên là
case
cái
first.
này tôi tiếp cận
Assess
với
is
xương tôi
the
sử dụng
exact
xương osteum
performance.
xeno.
Medication implant with
Tôi đã
advanced
loại bỏ
bonus
cái
is
implant cũ.
adequate indication of the implant limber. So I implanted these two implants. I closed the flap and waited on healing until the
Rồi
operative
sau đó
sinus
là sau
membrane
khi
is
loại bỏ thì
closed.
tôi sẽ đóng vết
This
thương
case
để
is
chờ
a
cái
very challenging
khác.
case where extra short implant cannot be placed. Vertical and horizontal three-dimensional augmentation surgery should be followed. These are the surgery photos.
Thì
The
sau đó
first
thì tôi
augmentation
tiến hành
surgery
là
was
mình
performed
sẽ thấy là
using
implant gắn
osteum to collagen combined with
tôi đã
allograft
sử dụng
material.
cái
A titanium mesh was selected and used
allograft
device,
và
and
xương
collagen membrane type 1
osteum.
was applied as a double layer, and the hole on the side was
Và
stabilized
màng
with
collagen.
this suture technique.
Rồi sau đó là có sử dụng cái mũi khâu đệm.
Finally, the background was achieved. Healing was uneventful. It looks nice, and membrane is positive in another
Cái
color.
việc đóng kín vết thương
Previous collapse
đầu nó rất là
image
quan
was
trọng.
released
Tôi đã thực
much.
hiện nó rất là tốt. Các bạn sẽ thấy.
And 6 months later, now it's time to
Rồi
place
sau
implant.
đó là 3
Two implants at the first molar side and the second molar side
hai implant đã được đặt
was performed in this new bone tissue.
trên cái
Even though a
lớp
substantial
xương
amount
nội
of
tạng này.
bone tissue was regenerated, it was immature bone, which needs protected for more consolidation. At that time, additional augmentation surgery was performed, and I selected bone graft material osteoxeno. Osteoxeno was applied to the outermost area
Thì
of
osteoxeno
the
được đặt ở cái lớp
newborn.
ngoài cùng.
As you know, this outer surface, outermost surface, is
Okay,
very
bề
difficult
mặt.
area to make a bone tissue.
Rồi sau đó thì tôi mới đặt màng lên.
Second stage surgery was
Sau đó
performed
cái
3 months
thứ hai
later to initiate implant loading.
thì mình
I needed to pay
tôi thấy là nó có
attention
những
to
cái
the
tập
quality of
dành
this
cho cái
newborn
hình
tissue. Doesn't it look good?
thì mình sẽ
The
thấy là cái
previous
lớp
image
xương
of
đó
newborn tissue
nó
has become more
rất là tốt.
consolidated.
Nhìn cái sự tái
This
tạo
is
xương
the
cái nó
outermost
rất là tốt.
osteoxeno. The severely traumatic case has now been converted into clinically acceptable state. And this case was followed up to 3 years.
Và cái ca này đã
Although
được
it was
follow up 3
not the
năm.
result of a main augmentation, but the result of additional augmentation, osteoxeno demonstrated its potential.
Thì các bạn sẽ thấy là cái điều đáng nói ở đây là cái xương sino ở
Osteoxeno
cái
demonstrated
phần xương
promise in the
mà
earlier
nó
case,
không có bị
but
tách
one
biệt
result
cái
alone cannot confirm its reliability. So I went on to apply it in another case. This is a horizontal augmentation case. I won't go into detail, let's move quickly. Maxillary site,
Ở đây thì tôi đã đặt một cái
inside
implant
the site, and the lateral inside the site showed the severely atrophied ridge. For the first augmentation surgery, I used osteoxeno combined with allograft material, which is my favorite combination. And titanium mesh was also used to protect the particulated graft material. Membrane was carbon light-size collagen membrane.
ở trên đó thì tôi
was applied.
vẫn sử dụng thêm một cái lớp màng collagen.
Healing was so nice. Reentry
Bạn
surgery
sẽ
was
thấy là chuyện
performed
lành
after
thương
6
nó rất là
months.
tốt. Sau
Still,
6 tháng
immature newborn tissue was found. Sometimes the thick soft tissue called pseudoperiosteum is usually formed beneath the mesh. And accordingly, some of the newborn was disintegrated from this newborn tissue.
các bạn sẽ thấy là khi mà loại
Although
bỏ
the
cái
implant
phần titanium
placement
mesh
is
thì các bạn sẽ thấy cái việc tái tạo xương nó rất
bone
là
is
tốt,
still
bởi vì
deficient,
cái xương nó còn tái tạo
so
ra phía mặt ngoài của
I
cái
need more volume.
sau đó
At
thì
the
tôi
time,
sẽ tiến hành đặt implant
I performed additional tibial surgery
tôi sử dụng
using
cái xương
osteoxeno.
với kích thước lớn.
And 6 months later, bone quality had improved significantly.
Thì mình sẽ
The
thấy là
newborn
sau khi
tissue
ghép
appeared
xương
clean and more consolidated, and osteoxeno was integrated well surrounding a newborn tissue.
thì như vậy là cái việc sử dụng xương seno nó cho phép là
Connective tissue graft was found for aesthetic purpose, and this is the preoperative status in this spinal outcome,
đây là kết quả sau khi
and this is 3-year follow-up. Once again, osteoxeno demonstrated the promising outcome in this case. Encouraged by these initial outcomes, I started to apply osteoxeno in the main defect. To see the true effect of
sau đó thì
osteoxeno,
tôi
it needs to be
tiếp tục
applied
sử
with
dụng
critical size
xương
defect.
để cho những cái ca
I will
khác
show
như
such
là
a
một
case
trường hợp
and surgery site of maxillary posterior
mình
site.
sẽ thấy là bệnh nhân đã nhổ răng
3 supply implants were supposed to be placed in the posterior area. However, with the bone quality at the first molar site, and
đây là vùng
this
răng
implant, sorry, bone quality at the first molar site was too soft.
các bạn sẽ
So
thấy
I
tôi
could
thấy là
barely
cái
place the
xương
implant at this site. The primary stability was very, very low.
cho nên là độ
Actually, I concerned about the implant migration into the sinus area during healing
và tôi rất là
procedure.
sợ cái tình trạng
I have experienced such a thing once before, so I decided not to place the first molar implant. Instead, sinus graft surgery via Crestor approach and the GBL surgery using only 100% of osteoxeno was performed.
sử dụng phối
Membrane
hợp
was,
xương
this is also a new product, collagen membrane 2 was applied as a double
và sử
layer
dụng phối hợp với lại
and stabilized with dentin fixation pin.
collagen 2
Healing was banned for during 4 months. Flat sloping and membranes projected narrow. Here are the foremost outcome at the time of BNP surgery. Still not resolved, the collagen membrane too was found here, beneath it, well-formed individual tissue, also found. A supine 2 implant was placed in only this regenerated bone tissue.
Các bạn sẽ thấy là
Even though enough primary stability was achieved at the time, this is what I wanted to test. Osteoxeno showed quite good result even in this critical size defect.
thì các bạn ở đây thì tôi muốn nhấn mạnh một điều đó là cái sản phẩm
Through the provisional restoration
trong những cái
loading, and the final corneal crown was placed.
đây là hình ảnh follow up sau
This case is meaningful because nearly entire implant surface was embedded in only regenerated
ca này nó rất là
precisely
các bạn
osteoxeno
sẽ
in
thấy
this
là
bone.
cái implant
It is functioning now successfully, and it will be interesting to observe this case in the long term.
kết quả ghép xương.
So, how was the performance of osteoxeno? Now, in the remaining time of first session, I will explain how to properly apply membranes to ensure
Thì ở cái
bone
phần thứ hai
graft
này tôi
materials
sẽ nói cho
function
các bạn nghe
effectively.
cái cách làm thế nào mà
In
tôi
other
quản
words,
lý
this lecture is also about how to maximize the effectiveness of the PBR membrane through the combined use of osteom products.
chi phủ của
I
màng.
have summarized a few techniques here. More cases using osteoxeno are coming up. The first technique, the membrane shear technique, I named it. This technique was designed for clinicians who find the trimming and handling membranes difficult. It is particularly suitable for horizontal augmentation involving one or two missing teeth sides. First, using an appropriate size rigid tie membrane, such as Jones type collagen membrane 1, is applied to the outer side of the defect without any trimming. This creates a pouch-like space between the defect and the membrane, and this first applied membrane provides rigid stability. Then, bone graft material are placed into this space, into this braided space. Next, second membrane is applied over the top of the defect, so tie membrane will be okay. Depending on the clinical situation, this second membrane may or may not be trimmed. This approach is much simpler and easier than trimming and applying a single large-sized membrane, and it provides better stability owing to double layer application. Here is a case that illustrates how the membrane shear technique is applied. This patient was a female in her 40s. This patient lost her anterior tooth when he was very young. As you are aware, the bone on the pontic side with a long eventual sphere tends to be very thick. The knife edge of this site does not allow the implant placement. In fact, fortunately, the majority of bone defect can be addressed by membrane fixation. Okay, here is the procedure. One piece of collagen membrane was placed as a graft. At first, show screw was used in this site to fix the membrane, but this ended up causing collapse of the membrane, so the space for bone regeneration was compromised. So this 4 millimeter screw was replaced with a 6 millimeter long screw. By doing so, the sufficient space was created. Using longer screw an effective way to achieve both membrane fixation and space making at the same time. The mixture of osteogenesis and allograft was applied into the created space, and the collagen membrane type 1 without any trimming was applied in this vertical area to block the bone defect gap, and another collagen membrane type 1 was minimally trimmed and applied to cover the coronal defect site. All of the site was securely stabilized. Tissue healing and provisional restoration was provided using remaining natural tooth. This is a 6 months outcome.
Đây là
The
tháng 6
CTA image shows the increased bone width. Remember the extremely thinness previously.
thì các bạn có nhớ là cái xương ban đầu.
Now it's time to place implant.
Bây giờ thì
Fixation
các bạn
screw
thấy
will remove. Remaining membrane is left intentionally without removal. This is for longer protection of newborn tissue. You can see abundant newborn tissue here. The quality was so good. You can also see the bleeding is inside here. This means vital bone is being formed. This is the outcome of membrane fixation technique, and this outcome is also a result of the combination use of osteon 3 and genotype collagen membrane 1. And connective tissue graft was performed to thicken the thin buccal gingiva. And 3 months later, healing abutment was connected without raising a flap. Through the scalpel impression procedure and through the using a digital process, provisional restoration was made and connected directly to the implant fixture. During the observation period, gum bleeding was found. Over-controlled restoration was considered as the main cause, so this provisional restoration was modified to the reduced surgical area. Then, the gum bleeding problem disappeared completely. Reflecting this modified provisional restoration, final zirconia crown was fabricated and delivered to the patient. Then COVID-19 occurred. During the COVID-19 period, this patient couldn't comply for recall visit for over 4 years. She only returned to the clinic after that. These are the clinical photos and radiographic outcome at the time. This is the pre-operative CT image. This is the CT outcome after 4 years. This is the CT image of the contralateral. When comparing, what is that? Sorry. Okay. When comparing the ridge width of this implant placed site and the contralateral tooth site, the ridge width of the implant site had been restored well and being maintained.
thì mình sẽ thấy là cái lớp vỏ
This
xương
is 6-year outcome. If you look at the CT images, this is a 6-month outcome. This is 6-year outcome. You can see the cortical alignment right here and the well-formed trabecular mapping here. As demonstrated in this case, when an appropriate bone graft material is used and the wound stability is properly ensured to allow it to function, the bone tissue is successfully formed and can be maintained in the long run. This is exactly the point I emphasized at the beginning of this lecture. This is the membrane shear technique. The second method I'm going to introduce is stretched membrane fixation technique. This method is also suitable for fluent augmentation. It is specifically designed for collagen membrane type 2. As you know, collagen membrane 1 is a rigid type and have a longer resorption period, making it excellent for cases where bone regeneration takes a long time. However, collagen membrane 2 compared to collagen membrane type 1 is less rigid type and has a shorter resorption period, but its tensile strength and elasticity are very satisfactory, making it very suitable for secure fixation procedure. First, membrane is trimmed minimally and fixed at one side, and screw or fixation pin was applied like this at one side. Then the membrane is stretched to cover the entire defect. While fitting is extended, the other side of the membrane is fixed with a screw or pin. The bone graft can be placed before or after fixing the membrane, but usually it is more convenient to secure the membrane first, then apply the bone graft later. On the lingual or palatal side, if the membrane size is large enough, it can simply cover the wound site. If it does not fully cover the defect site, additional fixation is needed, or it can be sutured to the palatal or lingual tract.
Nó đủ rộng á, thì nó có thể dùng dây sừng phủ cái phần sang thương này. Mình sẽ có thể là
Here is an example of stretched membrane fixation technique. This case is one of defect reconstruction. You can see the bone thickness, remaining bone thickness is less than 1 millimeter. There occurred also behind sensitive at the premolar implant site. Sinus graft via pressure approach was performed simultaneously. Here is the stretching membrane fixation technique. Once collagen membrane 2 was fixed at one side, this membrane was applied without any trimming in this case. And then mixture of osteum xeno and autogenous bone from the drilling site was grafted much, fill the defect like this slide. Then membrane was stretched to the medial side, not visible clearly in this slide. Another screw was used to fix the membrane at the medial side. Okay, someone may ask, this technique is similar to Saucer's technique, the famous technique using soft tight membrane. As you know, Saucer's technique involves the soft tight membrane bioguide membrane. Saucer's technique is a very wonderful technique. However, due to its soft properties, it needs multiple fixation. Accordingly, it is technique sensitive, the cost increases more. Right? Stretched membrane fixation technique using collagen membrane 2 has a great merit in terms of less fixation needs because collagen membrane 2 is a little more rigid than bioguide membrane. This is great merit. In my experience, two strip fixation or two pin fixation is enough to secure the whole, to obtain the whole wound stability. Then flap was closed, primary flap was achieved successfully, and 4 months later, second stage was surgery was performed. This is a newborn tissue made by the stretched membrane fixation technique. Look at this widened lifting control and the newborn closed. Any augmentation surgery could not produce this level of bone tissue. Although some remodeling occurred, this amount of bone was never deficient for long-term implant survival. This is the final outcome of this case. The lower first molar implant is a dentium implantium fixture, more than 19 years function. And this implant also molar implant, first molar implant, the lower side, also implantium, 14 years of function. And upper molar implant is a supplyingly 10 years of function. This slide seems to show the history of the dentium implant. And this is 2 years ago. Remodeling is still occurring. The third technique I'm going to present is classical, a basic technique, which is called membrane holding suture technique. This technique also known as periosteal suture technique, which is familiar to many patients. This technique involves a horizontal matrix suture between the buccal periosteum and the lingual palatal tract. While this method may not be as strong as securing the membrane with pin or screw, it works well for the common defect you usually encounter in daily practice. So this technique is frequently used combined with other membrane fixation technique for better wound stability. This is a listen to perform the case using membrane holding suture technique. There is a localized bone defect here. Bone is deficient in vertical direction, but this case is not difficult case because the missing span was rather short. But soft tissue closure will be problem in single tooth missing site. Anyway, this case was manageable case. Crest approach surgery was performed simultaneously, and you can see the vertically collapsed bone here, not visible, hidden by the gravity material applied at the sinus, but the implant was placed supracrestally around the 3 millimeter. Then, autogenous bone was collected from the leading site and from adjacent bone tissue using bone scraper, and autogenous bone was densely packed around the implant, exposed to implant surface. Then, osteon xenocollagen was applied to cover the whole wound site. And membrane was collagen membrane type 1, rigid type membrane. Rigid type membrane is preferred for wound stability, and there needs more. Membrane was secured using the horizontal matrix suture, membrane holding suture technique. Flap was closed, healing was uneventful. In this case, because of rigid device such as titanium mesh was not used, the augmented bone material might partially collapse. However, the result was quite acceptable. This approach can still be useful in certain situations, especially when less invasive methods are preferred. And this is the regeneration outcome. The newborn tissue was fully regenerated to cover the implanted platform. And the previously collapsed ridge and buccal side and lingual side all almost completely bone healed. I believe the use of osteon collagen along with the membrane holding suture in this case has produced optimal result for this implanted long-term survival. The last method is protected augmentation. This technique is particularly suitable for reconstructing vertical bone defect. Procedures involving the use of rigid space maintaining device like titanium mesh or zirconia plate or bone shells, irrespective of allogenic origin or autogenous bone origin. These procedures are known as protected healing procedures. Titanium mesh contains pore system to allow adequate blood supply to the underlying gravity material. Therefore, it is not cell-occlusive. As a result, rigid reconstruction with titanium mesh and similar rigid device is considered protective bone augmentation rather than guided bone regeneration. However, if a barrier membrane is added to any of these devices, it may then be considered as GBI. Anyway, procedures involving the use of a rigid space maintaining device other than membrane is considered as protective augmentation. I have already presented some cases of protective augmentation. I will show the cases. This case is vertical augmentation on the anterior side. In this case, customized titanium mesh was used. Due to legal problem, this procedure now currently is not popular in Korea as well as in China, but I hope this procedure will be popular soon. With the help of Dentium Digital Center, I designed this titanium plate in advance. These are the procedure. You can see the severely vertical defect in this right center inside the side. Also show the very thin niche on the left center inside the side. These are the prepared biomaterials. Osteon Xeno plus PDRM was prepared, and autogenous was collected from the tuberous site and mixed them with PDRM. And membrane was genus type 1 collagen membrane. Type 1 has the longer resorption period. This is more indicated in such cases. Here is the surgery sequence. Mesh or titanium plate was fixed first, and through the prepared hole, bone graft was filled densely. Composite bone graft is prepared, and collagen membrane type 1 was placed to block this hole using matrix suture and modified matrix suture and the suture. we will do, and primary closure should be accomplished. This is preoperative status. You can see deficient ridge here. This is the augmented tissue. And this is 6 months out. Mesh was removed because this is titanium plate, not a reinforcement. So minimal soft tissue invasion is found, and bone quality shows excellent quality rather than using the perforated structure titanium device. The use of appropriate bone graft material, osteosinone, has produced this result. Two supplying implants were placed in proper position, and another GBR surgery, which is known as reline GBR surgery, was performed. At the time, osteosinone collagen was selected as a graft material. Healing abutment connection surgery was performed 3 months after implant placement surgery. You can see still even more well-formed, mature bone was observed in this area. Through digital process, provisional restoration was fabricated, and after soft tissue maturation, reflecting the patient's wish to fill the embryo space, final crowns were fabricated in a more secure form. In the future, I will try the Mona Lisa as described from Professor Joe Casey. Okay, protective augmentation with rigid device is especially effective for more severe bone defect reconstruction. I showed this case, initial presentation of this case at the start of this lecture. As you remember, this patient did not receive any augmentation surgery. Considering the regular diamond were placed in here, initial bone thickness were rather deficient. In the end, these two implants were removed due to severe periimplantitis. Now let's look at how this case was successfully managed. 3 months after implant removal, implant replacement surgery was performed combined with simultaneous bone augmentation surgery. In spite of 3 month healing, severe defects still remains. Even with apex area, bone field did not occur. So I could barely place 2 superline implants, only engaging the sinus probe. As it was expected, the primary stability was very, very low. So I had to submerge this implant. For bone regeneration, you can see that here, titanium mesh was designed and fabricated, and I prepared this hole in advance. Mesh was fixed first, then bone graft material was fixed through this hole, then membrane was covered. Membrane was type 1 Johnson collagen membrane. This is result at 4 months. Periimplant bone defect was completely resolved, and buccal bone thickness increased much. Through the provisional restoration, about 3 months, this provisional restoration was replaced with this final juke. And this is the 4-year outcome. You can see the thickened buccal bone. This is never deficient for this long-term implant survival. In the first session, I have shared my clinical cases demonstrating how even severe bone defect can be successfully addressed with osteosinone and collagen membrane. As you can see, cases that once seemed challenging now within reach. Therefore, I would like to revise the title as follows. I would say that if a biomaterial demonstrates favorable outcomes repeatedly and predictably, it can be considered reliable. As you have seen from my cases today, osteon product, osteosinone and osteon 3 and collagen membranes fall into that category. While more longer follow-up is still needed, I firmly believe that osteosinone has the potential to become a world-class bone graft material. Okay?
Và cuối
Okay, I finished the first session. In the second session, you will see surgical techniques for primary flag closure. As you are aware in the first session, for successful bone regeneration, primary flag closure is an essential part. Failure to achieve primary flag closure will result in only dehiscence with consequently reduced or even complete failure of bone regeneration, especially in critical size defect reconstruction. So many clinicians are concerned about flag closure when they do bone regenerative surgery. And most of clinicians, including me, may have failed in achieving soft tissue closure. Every time we fail, we need to think about why we failed and look for the remedies. So throughout the second session, I'd like to suggest a solution for these problems. To achieve successful primary flag closure, it is necessary to manage not only the vocal side, but also the lingual side or palatal side. Due to the limited time, I'm gonna have to introduce only first part, vocal terrestrial religion incident part. I will explain conventional religion incident first, which is used generally, and then I will introduce other modified techniques and compare them with conventional techniques. I want you to understand the difference between these approaches and which one is better. Let's see a method in detail.
Và bây giờ chúng ta sẽ xem
Periosteal incision is a horizontal cut of the periosteum of the inside of the vocal flap. The point is to incise it perpendicular to the flap. Actually, it does not need to be a perpendicular. The important thing is the definite cut should be made. To do that, maintain the tension by pulling out the flap with tissue forceps or pincet, and then incision is made on the vocal periosteum using number 15 blade. Then flap will be extended. Before starting relieving incision, the first thing you should do is to change number 15 blade with the new one. Dull blunt blade does not work sufficiently. In this magnified image, you can see clearly the difference between the current surface with the new blade and current surface with the used blade. And lower left slide shows the properly performed relieving incision. You can see clean and definite cut, and you can also see the optimal position of the periosteal relieving incision. And this slide shows the improperly performed periosteal relieving incision. Incision is not clean, not continuous. Periosteum is torn apart, damaged severely.
thì nếu như mà cái
We need to understand the basic histology to do periosteal relieving incision properly.
nó không có liên tiếp á.
The magnified image of periosteum looks like this. There is a bone, there is a volcanic coming here, and this is periosteum area, and this is blood vessel. You can see the distribution of blood vessel is relatively insufficient from the 500 micrometer away. 500 micrometer is 0.5 millimeter. If you perform the periosteal relieving incision too deeply beyond this distance, we cut many blood vessels that induce profuse bleeding. Although using a deep incision, we can increase the flap, but there will be a very traumatic and tension will remain, so that is the cause of flap everting. So in order to make a traumatic periosteal incision, we need to do that with shallow depth of around 0.5 millimeter. The point is that the relieving depth about 0.5 millimeter is appropriate packing depth. We cannot measure the cutting depth during surgery. The recommended method is not to insert periosteum more than half of this entire blade width. Considering the blade width is about 1 millimeter, the recommended extended method is to perform periosterilizing incision at the half depth of this blade width without exceeding the entire width. Once again, deflect the flap, maintain the tangent and incise perpendicularly to the flap as possible. Definite cut should be made. And this should be performed with continuous manner without any interruption. The releasing incision should be extended to the vertical incision line. You can get more flap advancement after connecting the releasing incision to the vertical line. This is the single periosteral releasing incision classical method. According to the literature, it is reported that about 5 mm of flap extension could be achieved with this single periosteral releasing incision. We should make continuous complete cut without leaving any remnant fiber. This remnant fiber will induce tension, so this fiber must be cut. You can see the amount of extended flap length after the disc cutting the remnant fiber. However, this amount of extension length using only one single periosteral releasing incision may not be enough in some cases. This is the limit of this conventional releasing incision. 30 minutes is left, okay. I'll skip the first movie. Okay, then I'm going to introduce modified technique. First, multiple releasing incision technique. At the single periosteral releasing incision, if the flap do not be extended enough, we tend to incise the muscle layer more deeply, like this. So there will be much bleeding, we cut many blood vessels. This is traumatic method. If you want to extend flap further, it's better to make the second incision at the other side with shallow depth. If you incise the same area repeatedly, it becomes inside the muscle layer deeply and tension still remains. So making the second incision at the other side with shallow depth is desirable. This picture shows the second releasing incision. You can see the first releasing incision and the resultant length in the flap. And you can also see the second releasing incision here. This method is less primary. However, performing the second periosteral releasing incision with number 15 blade is not so easy. And the effect of a second periosteral releasing incision using a blade is somewhat limited. So, to perform the multiple periosteral releasing incision more precisely and delicately, scissors technique was developed. With the sharp-ended scissor, cut the periosteum carefully from one end to the other end. The cutting depth should be shallow, around 0.5 mm, and muscle layer should not be touched deeply. We can do multiple releasing incision technique more easily like this way. Wide scissors instead of a blade, the reason is the tactile sensitivity is more better when using a scissor. Since the flap length can increase by an average of 5 mm using one single periosteral releasing incision, theoretically, flap length can increase by about 50 mm if the releasing cut is done 3 times, right? This picture, I quoted from literature, the initial motion of the scissors technique. An area where the flap thickness is relatively, preferably 2 mm, is the optimal starting point of this technique. This clinical photo I also quoted from literature shows the process of the scissors technique. This slide is from my case. You can see clean cut using scissors technique here. Periosteum was not damaged severely. It looks clean. This is the illustration showing scissors technique. Using number 15 blade, make a short but definitely clear cut. Then, connective tissue was exposed, and exposed connective tissue will be the initial incision point using scissors technique. Scissors is inserted into the small open gap and proceed forward by cutting through this tissue. This motion is repeated away from the first incision line. If necessary, the third incision is Finally, the flap length extended in this way is sufficient to achieve primary flap closure in most of the cases. Okay, let's take, I will show some video, one video, short video, showing the scissors technique. I'm sorry, this one. I will skip the first part. This is the typical model. First pin flap was raised at the molar side of the key. Okay, now it's time to release the flap. Find the level stick area of gingival. Then using a number 15 blade, make the shortcut. Definite indentation should be formed. Then scissor is inserted through the exposed portion and advance the forward direction. Then flap is released, periosteum is clean, not damaged, blood vessel is not cut severely. Okay? Okay, go back to the slide. In my experience, this technique is very effective in maxillary anterior area or scar tissue area. In maxillary buccal anterior side, where teeth were extracted a long time ago, bony concavity with strong muscle insertion exists always, right? So if you do not use the blade carefully, perforation of the tissue at the undercut may occur. So scissors technique can be a more appropriate technique when severe bony undercut exists. And visibility and accessibility is good in anterior side. We can apply this technique in this site. To regenerate the lost buccal bone tissue of this patient, I used the allogenic bone block for space-making device. I fixed this allogenic bone graft at the most severely resolved site as a column. Then I applied a sufficient amount of bone graft particulated bone, osteoid-free, and mixed with the allogenic material at the remaining part. Then I applied just carbon collagen membrane, 3 pieces of collagen membrane was applied. One other side, 15 by 20 millimeter size implant was placed, and whole wound side was stabilized with membrane holding suture. I will show how I could achieve the primary flap closure. With sharpen this scissor, I cut the periosteum 3 times at different sides. You can see 1, 2, 3 incision line. This is CT image after 6 months, showing the successful augmentation outcome. Now it's time to place implant. After flap or glazing, the intact collagen membrane was found underneath the newborn tissue was found. Successfully augmenting the bone is observed. In aesthetically sensitive area, a tiny means the implant position would lead to poor aesthetic outcome. So once implants were placed alone, aesthetics would not be achieved by any prosthetic compensation. So in this case, I utilized the surgical body system, and 5 implants were placed in proper position. Without this implant, primary stability was achieved sufficiently, so the provisional restoration was provided to the patient. This is 2017. At the time, I bought dentistry catchment system first. So I only tested that system. So designed and fabricated zirconia process very quickly.
Trong cái năm này tôi
But I want to call this the second provisional restoration. More than half a year has already passed since the first bone augmentation surgery. To me, it seems that soft tissue correction and new restoration are needed. You can see an harmonious gingival here and lateral shell crown. I was not satisfied with these things. So although the patient has no complaint of these prostheses, I was considering to make a new prosthesis at the time. Anyway, bone regeneration was successful in this case. You can see confirm this with the CT image. I could achieve primary flap closure by multiple releasing incision technique. I performed the multiple releasing incision technique with the scissors technique. That is the point of this case. In the end, I performed the apically positioned flaps for soft tissue correction about 1 year later. Then a new provisional restoration was provided to this patient. This is the ugly process. I call it the second provisional restoration. This is the new provisional restoration. It looks much better. After complete soft tissue healing, actually I waited about 1 year for soft tissue maturation. In the end, new final zirconia prosthesis was designed and fabricated like this. Now I'm more satisfied with this result. This is another case using scissors technique. The surgery site of the wall was lower excellent posterior area. You can see the atrophied bone here. Besides the very thin edge at the proximal site, low vestibule with strong muscle insertion was the problem. Scissors technique is more indicated when the strong muscle insertion area. Okay, this is one old defect. Completely healed ridge. GBR surgery was performed using the memory, this space-making device. This is a ready-made product. Belgium developing this kind of things, so we will make in the future. Okay, for primary flap closure, parasternal incision with scissors technique was performed. You can see the very thick tissue here. In this situation, scissors technique is very effective way. You can see the very clean surface.
sẽ thấy là cái bề mặt nó rất là sạch.
Release the flap here. Bone graft was mixture of osteoinjury and autogenous form. Membrane was also membrane type collagen 1.
Và cũng màng cái màng đây là collagen 1.
BNT surgery was performed 4 months later. You can see the newborn tissue here. How is it? The quality shows excellent quality. The osteoinjury was integrated well with the newborn tissue. Any of the biomaterial can achieve this outcome. Through the provisional restoration, during the provisional restoration period, freezing evaluation was performed to correct the low vestibular problem. And this is the final zirconia prosthesis and 2-year outcome. Okay, next I will introduce the modified technique, which is called brushing technique. The use of conventional releasing incision is not sufficient frequently for passive flap advancement. Brushing technique was suggested by Dr. Londa from Italy in 2015. He reported about 20 millimeter of flap advancement with this technique. Technique is very simple. This is a schematic diagram of brushing technique. After conventional releasing incision with shallow depth, with number 50 blade, incision is repeated using sweeping motion or brushing motion, apical coronary. Exposed connective tissue is scraped. Then flap will be released. Once again, deep incision is not recommended. It should be avoided. More specifically, first, perform conventional parallel scale releasing incision with number 15 blade. Then connective tissue exposed by single parallel scale releasing incision in the inner part of the buccal flap represent the work area where the brushing technique is applied. Keeping the flap in tension, the blade is used with brushing movement over the entire area to interrupt the residual fibers.
Đó là dùng kẹp giữ vạt để giữ cái vạt căng.
Then flap will be extended enough. The entire side should be scraped. As Dr. Londa described in his report, separation has important meaning. That means preservation of the innermost layer without damage is crucial. This case demonstrates vertical and horizontal bone augmentation using brushing technique. You can see the severely atrophied ridge here and here. And this slide shows the detailed surgical procedure with brushing technique. First, the single periosteal religion incision is made. Clean cut is important from one end to the other end. Then, starting from the cutting area, expose the connective tissue using a new number 50 blade. And up and down sweeping motion is applied to release and extend the flap. And anterior side release and posterior side release. Perioscum was not damaged severely, rather it looks clean, and the most layer was not exposed at all. This is the prepared biomaterial. Titanium device was prepared in advance, and in this case, the collagen membrane 2 was utilized, and bone graft was autogenous bone, and osteoxeno in white color, and allograft. All mixed them with the PDRL. The same surgery sequence was applied. Plate was placed first using a screw, then bone graft was placed through this prepared hole, and this hole was blocked using the collagen membrane. This is the outcome in this case. Although some remodeling occurred after loading in this case, however, this case was successfully completed. I need you to keep in mind that brushing technique was used to achieve primary flight closure in this case. Let me give another example using brushing technique. At first glance, these two implants seem to be very well, but if you take a close look, the first molar implant, this implant, was placed too buccally. Probably thin buccal bone remained at the first implant surgery, but after loading, thin buccal bone must have been resolved 3 years. Hair implantitis occurred, and this implant was removed. Due to the removal of the previous implant, scar tissue was formed. I would like to say that in case of hard scar tissue, to release the flap, brushing technique is more effective. This is the case of this bone defect reconstruction. At the single periosteal incision, brushing technique was applied to the entire area. As usual, membrane was fixed first, and composite bone graft was applied, and primary flap was achieved. This is the newborn tissue after 4 months, right? The reason of first implant failure was the malpositioned implant, too buccally positioned implant. So at that time, implant should be positioned in more precise direction and position. So this implant was moved, placed more lingual side. Apical coronal depth is also important. Due to the previously bone loss of anterior side, this implant was placed a little deeply. Anyway, this case was successful and followed up to 6 years. You can see the newborn tissue at the buccal side. This is an area where the bone is completely lost. Okay, lastly, from now on, I'm going to explain double flap technique specifically. 50 minutes is left. Okay, double flap is great, but nowadays I combine it with the brushing technique frequently. I introduced conventional leading incision already when I was a beginner. I did parasternal leading incision in this manner. Thanks to this technique, I could resolve lots of cases successfully. But sometimes I couldn't get a primary flap closure, so I have experienced flap exposure. There was some deviation. The reason of flap exposure is the tension, which is left even at the parasternal leading incision. Conventional leading incision is performed after reflecting flap, so incision is made on this muscle layer. This red color indicates the muscle layer. So after single parasternal lesion incision, if the flap would not be extended enough, any clinicians tended to incise the muscle layer deeply. So there will be much bleeding. More importantly, flap to be extended includes this thick muscle, so tension remains. This is the reason of flap exposure after leading incision. To overcome this problem, new method is introduced. Nowadays, I use modified technique to extend the flap. One of them is this double flap technique. Okay, the difference between the double flap and the conventional leading incision are the initial incision point and the thickness of the outer flap thickness. In double flap technique, initial incision is made above the thin muscle layer like this. Starting point is here, and the blade run over the thin muscle layer. And by doing so, we can make a thin outer flap and exclude this thin muscle. So less tension will remain. But in conventional method, as I described, thick flap including this thin muscle will be extended, so tension remains. That is the big difference between the two techniques. And anyone can understand easily this thin flap will be extended further than this thick flap involving thin muscle layer. Double flap consists of full thickness flap and partial thickness flap. First, begin with the full thickness flap. To place implant and to do a GBR surgery, upper part of the bone should be exposed. Make a full thickness flap to the area which is thought to be a defect bottom or mucogingival junction area. Then, from this point, with new sharp number 15 blade, prepare the partial thickness blade. Repeat this motion several times. Always be careful not to perforate the buccal flap. Keep an eye on the buccal side frequently. And the point is to make the outer flap thin and leaving the thick periosteum attached to the bone tissue. Then double flap is completed. Then this outer flap, this outer thin flap will be extended further in an easy way without any tension. From several literatures, we can find other similar techniques having different names, but basically these techniques are the same in terms of using a partial thickness flap. All these studies reported very little membrane exposure rate even in compromising case. Here is a good example of double flap technique. This patient lost first molar tooth when he was very young, and the second premolar tooth so decayed, so this tooth was removed. But the patient was relatively young, middle 30s. She wanted to save the second molar tooth, so root canal treatment was performed at this tooth. So I decided to observe in the long term. Anyway, the surgery site, this second premolar site and the first molar site. This slide shows extremely thin, very unfavorable condition for implant placement surgery. This is one of the defect. So one of the defect doesn't have a defect bottom. So I open the flap, full thickness flap, just to the mucogingival junction area. And from this area, partial thickness flap is prepared like this. You can see clearly the double flap in here. Big periosteum was here, and the outer flap was in like this. Then, two supplying implants were placed.
Rồi sau đó là tôi đặt hai
This is a
implant.
4 millimeter diameter, and this implant is a 4.5 millimeter diameter. Implants were protruded out of bony envelope. Defect type was non-self-contained one defect. Even though the more narrow diameter implants were used, thread exposure would have occurred. A strategy of bone augmentation despite the use of narrow diameter implant still remains valid. At the GBR procedure, using membrane fixation technique and using membrane holding suture technique, primary flat closure was achieved. Bone graft I used was a mixture of surgery and autogenous scar. Due to the limited amount of drilling site, I collected autogenous scar from the posterior area. And important thing is that this membrane holding suture should engage this periosteum area at the bottom area. Healing was only been performed after 5 months. I performed second stage surgery. Opening the flap, I could see the contact collagen membrane protecting the new bone tissue. I carefully removed this collagen membrane to expose the cover screw. You can see at the closed loop, you can see the small blood vessel here. This means this is a vital bone. And then I performed the apical infusion of the flap to make the attached keratinized tissue around the implant. This is the preoperative worst condition, and this is the regeneration outcome. You can compare that with these two slides. Through the digital process, provisional relation was fabricated. I wanted to observe the prognosis of this second molatius, which the critical treatment was performed before. So I waited 1 year. After that, after confirming that this periapical lesion disappeared completely, I proceed with the final crown procedure of the second molatius.
Và tôi đã làm lại
This is the 1 year outcome. This is the 1 year outcome. You can see that this X-ray outcome here and here. There is a whitish mass around the buccal side of the implant. This side is a previous defect area. As I mentioned in the first session, if osteointegration is a reliable bone material, it should act as a scaffold supporting new bone, preventing excessive resorption, and allowing proper remodeling. Did it perform as expected? I show the follow-up case. This is 5 year, and this is 8 year at the latest visit. What do you see? The cortical lamina is formed evidently, trabecular pattern is formed normally, and the implant bone level is formed above the implant platform level. Okay? This is a real mature bone. This is the performance of osteoid 3 and the collagen membrane. One more thing I want to notice is that the method used to achieve the primary flat closure, in this case, double flat operation. Okay, I have to skip this case. I will show the clinical video showing the double flat and the brushing technique. I have to skip the first part. Sorry, our electron is very uncontrollable. Sorry. Okay. Okay, full thickness flap is made. This is physical model. There is no defect bottom here, so full-thickness flap is made just above the mucojunctional junction area. From this point, using a new 15 blade, 15C blade will be okay. like this. Always check frequently at vocal side not to perforate the flap. This is a 15C blade, partial skin flap is made. The point to make the outer flexing and the thick hair steering layer should be attached to the bone
Đây
bed.
là mình sẽ phải làm sao để bóc tách cái đoạn bánh phần lông, tức là cái lớp mình bóc tách ra nó mỏng. Còn trong khi đó
You can see very delicate motion here. This remnant fiber should be cut. Yeah, remnant fiber should be cut here. Then I usually combine this technique with brushing technique. A bend down motion is applied to spread the entire flap. Then flap will be extended further.
Và khi đó thì cái vạt sẽ căng tốt hơn.
Repeat this motion slowly to get a sufficient amount of extension.
Mình sẽ thực hiện cái thuật này một cách từ từ để đạt được cái độ
Okay. Always time is limited. Okay, it's time to label. So far, I introduced flavor advancement method using modified techniques and comparison with conventional technique in the second part. More techniques, for example, lingual releasing technique, palatal